We're jumping right into Hep A. That's okay.
Who here is familiar with the Hep A outbreak nationally, or that we have one in North Carolina?
Yes, okay. You're doing
This is great.
Yeah, this is
good.
great.
All right, so hepatitis A, we've had an outbreak we've been tracking since about 2018, but nationally there's been an outbreak of person-to-person transmitted hepatitis A since 2016. It started mostly out west, a little bit in the Midwest, but really tons of cases. If we look at the cases to date, it's almost about 43,000 over the last 5 years. To give you some point of reference for what we used to see for Hep A cases prior, we'd maybe see 1,000 cases a year, maybe every 2 years. So obviously many more cases. The other piece of this is because we're looking at person to person, and the folks that are at risk are already have complex medical conditions. There's a higher rate of hospitalization and a higher rate of mortality. So folks may have comorbidities of hepatitis B and C along with Hep A, which raises your risk of severe disease.
Yeah, I think we have kind of maintained right about, like Christy said, co-infection with other viral hepatitis, and especially C. Throughout our outbreak in North Carolina, we have been hovering around half of the cases of Hep A also have Hep C. Yeah, go ahead.
It typically has to do with hygiene. So less access to hygiene products, less access to water, all of those types of things, because Hep A is fecal oral. There's just a higher risk there. And the same, a lot of the common risk factors are overlapping risk factors, right? So we see that risk kind of compound on itself.
I think the clicker may have stopped working. Click, click. Sure.
Is it on?
I don't know. I don't think I did anything. Yeah, it's on. I don't think the clicker is working anymore. It's still on, but it's not clicking. Any thoughts? Can anyone else? Oh, wait. Oh God.
Oh, geez.
Yes.
Okay. So this is currently where we are with the national hepatitis A outbreak. So all of those in gray, all the states in gray are outbreaks declared over. And those are a lot of the states that had started out in 2016. And part of that is increased efforts for vaccination. Part of that is increased prevention messages around hepatitis A. But the other part of that is once you get folks vaccinated and once those prevention messages are out there, the folks who are susceptible, that goes down. And remember, with hepatitis A, you end up having natural immunity after having an infection. So if you survive your Hep A infection or your Hep A illness, that's another person that's kind of adding to that herd immunity. So ultimately, there's less risk of those outbreaks continuing and having really long, prolonged outbreaks. North Carolina currently still has an outbreak.
And also, I think it's really important to note when we talk about Hep A, you can see like we're doing a little better than the states immediately surrounding us. But I think that's also kind of cause for concern for us to do our best so that our blue doesn't become a darker blue.
So how are we doing? This is a big, not easy to read graph, but we have had actually year to date a little bit over 1,100 cases associated with this outbreak over the last few years. But in the last 6 months, we've had almost 40% of those occur in the last 6 months. So we really saw an uptick of our cases in the last 6 to 12 months. And this is what our Epi Curve looks like. So we saw our peak kind of right around the spring, and we saw another peak right around the fall. And we're going down. It seems to be a true decline. We're hoping that it'll stay the same, but we are still promoting vaccination. We're still promoting prevention measures, hygiene kits, safer drug use, safer sex, just to make sure that we don't see another peak, right? We don't want to have to have a huge response again, right? You want to make this be part of general preventative care, is including that vaccine message in there. And then where are we seeing our hepatitis A outbreak? We've mostly seen it in the western portion or the western half of the state. That's not to say that risk doesn't occur in the eastern portion. A lot of this has to do with testing, access to care. We have seen our peak for hepatitis A during a pandemic. So folks who regularly would probably seek care in a hospital or an ED might not have, especially if their symptoms were mild. So we're probably missing some cases there. But largely, this is where our Hep A outbreak has been centered over the last few years. And then this is just another way to look at it. So looking at case rates, you can see the difference, right? So there are some counties in North Carolina that are really population dense, some that have really low populations. So I always look at the rates when we're looking at these maps to see kind of what the risk is. And then what are our Hep A risk factors? I mentioned it before. So men who have sex with men or folks who are engaging in anal sex, drug use, and folks who are unhoused are at the highest risk for hepatitis A. In North Carolina, we actually mostly see people who use drugs as our highest risk, and folks who are unhoused as our highest risk.
And I think it's also important to note that this is self-reported risk. So this is folks comfortable disclosing to the clinician that they use drugs, right? So whenever I look at this number, that this is, almost 280 out of 418, but I would guess it's possibly a little higher because this is just who was willing to disclose.
Well, and so to be a part of this outbreak, the case has to self-disclose some risk, right? So there might be people who don't want to talk to the health department. There might be a lot of people who don't want to talk to the health department. And so we are likely not seeing the full gravity of how big the outbreak is. This is just what we're able to capture with surveillance. And I mentioned before the higher hospitalization rate, that's because of comorbidity risk. So folks who have existing or history of hepatitis C or hepatitis B, who also have hepatitis A, have a higher risk of liver failure, hospitalization, and death, likely due to the already kind of potential damage of the liver because of those infections. So that is why we also want to make sure that if folks are testing positive for hepatitis C, testing positive for hepatitis B, or HIV positive, that we're offering Hep A vaccine when we can. And then this is just tracking vaccine administration throughout the outbreak. You can see that we had quite a bit going on, and then something weird happened in March 2020. And so we saw a dramatic decline in vaccine, though we have seen the efforts around Hep A vaccination increase.
And it is if you work one-on-one with individuals, it's an easy way to kind of sneak a Hep A conversation in with a COVID conversation, because we want to talk about vaccinations, and then we also want to talk about like doing your best with all your like personal hand hygiene and that kind of thing, because that's really your best bet with Hep A prevention. So those are easy to.
And you can receive hepatitis A vaccine and COVID vaccine at the same time.
Mm-hmm.
So co-administration is a possibility, and a lot of times the health department, Hep A is for free, along with your COVID vaccine. So that's just something.
Same with flu too, right? You can
and flu as well.
Put them all together.
All right, hepatitis B. I'm going to try to breeze through. I don't know how we're doing on time. So
yeah, what time is it?
13.
We're halfway done. Sure.
All right, so acute hepatitis B, we talked a little bit about how we should be seeing this go plummet to the bottom, and we're seeing this increase in acute Hep B. How are we doing compared to the US? We are seeing higher rates of acute hepatitis B. With that said, not every state tracks acute Hep B. Not every state has an enhanced surveillance system. So I like to think that while we definitely have an issue to be concerned about, we're able to track it a little bit better than some of the other states. So that's why we're a little bit above. And then when we look at acute hepatitis B by gender, I think it's important here to note the difference. So when we look, we're going to look at Hep C in a little bit, and you'll see that Hep C looks very different. So I just want you to just take a photographic memory shot of this, and for when we look at the next one. But we're largely seeing, you can go to the next one. We're largely seeing more men than women with acute hepatitis B. And we're also seeing an age group of about 35 to 55. Does anyone know why that age group is sticking out? So this is probably folks who didn't get the birth dose of Hep B, right? So they missed the boat because they were born before the time that was mandated. And here we are. But this is another important thing where we want to check with folks whether they're vaccinated for Hep B, because that's also something that's available and a tool for them to help protect themselves. And so acute Hep B rate by race ethnicity, if we look here, largely with acute hepatitis B, we're seeing not much of a difference between our white population and our Black African American population, but a pretty stark difference with the rest. When we think about chronic hepatitis B, we would see the Asian Pacific Islander population be much higher because typically with chronic Hep B, it's folks who are born from endemic regions or countries where vaccine and testing is not available as often. And then when we look at self-reported risk, hepatitis B, because it's both sexually transmitted and transmitted by blood, we don't do hierarchical risk, so folks can claim multiple risks. So when we look at this, it might not be that heterosexual sex is causing the second highest cause for hepatitis B being transmitted. It's just that folks have claimed that in other things. But largely our self-reported risk that is most commonly reported is injection drug use. And then looking at acute Hep B by county, we always have a few hotspots with hepatitis B, but they're almost never the same county each year because of vaccine. The same thing with hepatitis A, where you ultimately will have kind of herd immunity, and the folks who are susceptible will ultimately either be immune or vaccinated. It kind of moves from county to county. So it's a good thing to know what counties are hotspots, but always just assume there's a risk wherever you are. And then chronic Hep B rate looks a little bit different, a little bit higher. And then this looks very different from acute Hep B, right? So this is telling us that the folks that are chronically infected with hepatitis B are not really necessarily the same folks who are being acutely affected with hepatitis B.
And we'll talk a little bit more about the change from acute to chronic for Hep B and for Hep C in a couple minutes. So do you want me to go ahead? So we wanted to include this, and I think partially because not a lot of people were aware that this happened earlier this year. And also it really, as you can see, it affects people who use drugs. And so we thought that would be important for folks who work with folks with HIV. Just in the case that it's a good thing to chat about. So we had an outbreak of hepatitis B in one county in North Carolina in the first couple months of this year. The first case was back in the beginning of January, and then the most recent case was in April, as you can see. So it was 6 new cases of acute Hep B, which doesn't sound like a lot, but that is way more than we would expect for that period of time. And they also, all 6 of them reported injection drug use specifically. And so that is kind of cause for concern because we know that that is kind of a way that there could be even more cases in a short amount of time.
And I think one of the other things about this outbreak that was really important to see is that 5 of the 6 cases were acutely affected with hepatitis A, and over half of them also had hepatitis C. So we're talking about folks that are at a higher risk for more severe illness. Obviously, they were hospitalized. So it's something just to, when you see someone who is being tested for hepatitis C, always offer vaccine or offer testing if possible for other hepatitis.
Yeah, I think it's a conversation that we don't have very often in drug user health because like we said, Hep C is kind of what everyone knows a little bit about already and is talked about the most, but instances like this, this is why we want to make sure we're discussing B as well. Okay, now we're going to talk about Hep C.
Hep C.
Breeze through our questions for the sake of time. Oh, go ahead.
In the chat, there we go. Okay,
Great.
wow. So this question is from Carissa, and it is Hep A with drug use transmitted via shared paraphernalia? If so, I heard oral. So from sharing pipes, joints, blunts, straws, etc.
Yes. Shorter is yes.
Yeah, the short answer is yes. Right, it's not transmitted in the same way that B and C are when we think of like blood to blood contact, but it is it's that like lack of access to hygiene materials that is kind of making that risk happen for Hep A. It's folks who don't have access to be able to wash their hands. And that's a really important thing with Hep A is that washing your hands is ideal. You can use hand sanitizer, but because of the type of virus that it is, you want to wash your hands. You want to be able to remove it physically from your skin. A hand sanitizer is not going to do the trick, which is harder if you're, if your housing is kind of up in the air, then having a place to wash your hands with soap and water is a little bit more difficult. And we just see that overlap sometimes with folks who use drugs. Thanks, that was a great question, thanks. This one?
Yeah, I don't think we started. Oh. All right. Acute Hep C, and Morgan did raise. So we are talking when we talk about surveillance with acute and chronic, and these are based on surveillance definitions. So they're not clinical definitions. So when Morgan talks about acute C and chronic C, and she's talking about specific illness, she's talking about folks who are either had new transmission and then have long-term illness, where these have very finite kind of criteria to fit acute and chronic. So when we look at acute Hep C, Hep B, and hepatitis A, they are at the liberty of surveillance, right? So what we can see, what folks are willing to tell the health department. So they're more of a proxy to let us know what's going on. They're letting us know from year to year what's changed. Are we seeing an increase, and kind of using that as a tool? But they're not a true level of prevalence or incidence. They're just giving us kind of a gauge of what's happening in the state. So when we look at acute Hep C, obviously we've seen this before. It's been increasing since about 2007, 2008, when we started seeing increases in unintentional overdose, increases in drug use, increases in opioid use. And it's, as you can see, gone up and down. I think this is likely 2019. 2020, we did see a deep decline, and that's likely access to healthcare and testing. So it's going to look like we kind of bent the curve, but until we see what the next couple of years look like, it's likely that's not true. But we're seeing the same increases we're seeing with acute hepatitis B, right? It's just this one started a little bit earlier. And then this is what I was talking about when we talk about gender. So there's less of a differential here between men and women who were affected by acute hepatitis C than what we saw with hepatitis B, because there isn't that protective layer of vaccine or immunization. Anyone's at risk. And also there's not really necessarily a gender differential in people who use drugs either, right? Anyone can use drugs. So anyone who is actively using drugs or has used drugs in the past is at risk for hepatitis C. And then when we look at age distribution, also different, right? So we're seeing a much younger than traditionally thought of hepatitis C population. So who do we think of when we think about hepatitis C? When we
Who's on the Gilead commercials?
Who's on the commercials? Baby boomers, right? So we hear a lot about baby boomer testing. Prior to a couple of years ago, a lot of talk about baby boomers getting into treatment. And part of that is because a lot of the illnesses occurred very far in the past. So it's getting folks into treatment to be able to help kind of backtrack on any liver disease or liver damage that might occur. But one of the pieces of this is getting people tested as early as possible, because then they won't have to go through that, right? They can get into treatment. They hopefully will not have any fibrosis or any kind of cirrhosis or any kind of liver damage. But the other important part here is that because we're seeing more women that have acute hepatitis C than in the past, or hepatitis C than in the past, and we're seeing a younger population, there's a risk of perinatal transmission of hepatitis C. So making sure that pregnant individuals are being tested during their pregnancy twice if a risk is existing, and making sure that baby's being tested properly as well. And then when we look here at acute Hep C rates by race and ethnicity, largely white population. Also, our American Indian, Alaskan Native population is greatly affected by hepatitis C. And then self-reported risk. This is a different type of risk than when we talk about acute Hep B. This is hierarchical risk. So what is the risk that is the biggest likelihood of causing the transmission? And in this case, about 47% of our cases are self-reporting injection drug use. If we incorporate non-injection drug use in there, it ends up being about 2/3 or 3/4 of the folks that are being reported. And then our map. So it looks different than the Hep B map, right? So this one also will move around quite a bit. If the county you're in does not have any reported cases here or is on the lower end, that doesn't mean that it's not happening. It just means that we're not capturing it in surveillance. And then chronic Hep C, which in North Carolina has only been reportable by electronic lab record since 2016, is obviously much higher than the national average. But with that said, again, there are a lot of states that haven't had surveillance for hepatitis C for up until this year. So we're likely capturing quite a few more cases than other states. And then this is when we talk about baby boomers, right? So our chronic age distribution is really showing our quote unquote new population, our folks who are newly susceptible, and then our baby boomer population for testing, right? And you can see that there's a difference in gender distribution as well there. But it's really showing this bimodal distribution, which is showing us two things, that we're not capturing all of the acute cases. They're probably falling into here eventually, but also that a lot of folks are probably going on to have chronic Hep C. So they're not clearing their infection, which does happen 20-25% of the time. They're going on to have a long-term infection. And we can skip through this one. We actually don't capture many demographics with chronic hepatitis C because it's electronic lab record and they're not investigated.
Which is not ideal. I'll work on it.
So when we look at by the rates by county, chronic Hep C is one of those places where increased testing can cause testing bias because we don't have the checkpoints that acute Hep C do. But we are seeing large distributions in the western part of the state and the eastern part of the state. It is not a coincidence that the eastern part of the state has a universal testing initiative in those counties. So that's likely why we're seeing so many cases crop up there. But again, probably a risk everywhere. And then when we look at co-infection, looking at folks who are living with HIV, folks who are living with Hep C and hepatitis B, there's quite a bit of overlap. With that said, when we look at our acute Hep B cases and we've done investigations, a lot of the time we found that up to 65% of the folks with acute hepatitis B have chronic hepatitis C. So we're not capturing all of this, but this is just giving you kind of a good idea of where overlaps might occur.
You want to skip through?
So what are the take-home notes? Hepatitis A, B, and C are on the rise in North Carolina, specifically in folks who use drugs, folks who are incarcerated, people with unstable housing or experiencing homelessness, and then men who have sex with men. Newer cases of hepatitis A, B, and C tend to be younger than the traditional kind of baby boomer population. But with that said, people who are not within the demographics that we're seeing are still at risk. So there are people over 35 who use drugs. So anyone who is specifically in these risk groups are at risk. And then perinatal hepatitis B and C are a concern. So hepatitis C, there's about a 5% vertical transmission rate. There is actually required testing. Technically, that this has not been changed since then. CDC did change their testing requirements to include prenatal screening for hepatitis C for every pregnancy. And there is no dedicated perinatal nurse, but we do have one in our program that we have turned into a perinatal nurse. And then hepatitis B, with higher rates of acute Hep B and chronic Hep B, we're going to see higher rates of potential vertical transmission. The nice thing about Hep B is that there are some post-exposure prophylaxis and vaccination options.
Okay, so now we're going to talk a little bit more about how to have conversations with folks, especially if you work with people who use drugs, work with people who are at high risk for HIV, folks who already have HIV, just that we're hoping that this will be helpful and make it easier for you to like integrate conversations about viral hepatitis into your like risk reduction conversations with folks. So this is our favorite basic little slide here because we love emojis. We discussed all of this already, but I'll go through really quickly. For hepatitis A, transmission is fecal oral, which is why we focus on hand hygiene and just general personal hygiene for prevention, in addition to encouraging folks to get vaccinated. And also good to note that if you have Hep A, like Christy mentioned, it's self-limiting. And then once you recover, you have lifelong immunity in the same way that you would if you were vaccinated, which is good to know. For hepatitis B, transmission is very similar to that for HIV. So you can kind of work that into conversation together, blood-to-blood contact, sexual contact as well. We also have a vaccine for B, which is great. So we want to encourage folks who are at risk to get vaccinated. Hep B cannot be cured. It is treated in kind of in a similar way to HIV with kind of lifelong antiretrovirals. And then for hepatitis C, it is explicitly blood-to-blood contact. It cannot be vaccinated against, but it is curable, which is great.
And I think I mentioned it for C that most folks go on to be chronically infected with hepatitis C. Some folks will clear, usually about a quarter will clear their infection naturally. They won't be immune. But for hepatitis B, if you're an adult and you have acute hepatitis B, it's actually 90% cure rate, so our clearance rate. So only about 10% of those folks are going to go on to have chronic infection.
Hello again. Even though I've seen this presentation, I always have like new questions. So what is it in the difference between Hep B and C that makes one curable, but not the other, and one able to be vaccinated, but not the other?
That is a difficult question. So they are very different viruses. So that's probably likely the part of it.
They're lumped together for the sake of, like we mentioned at the beginning, that symptoms look really similar. And I think that's why they are kind of lumped together, is because the illness that they can cause looks very similar. But the viruses themselves, I believe, are quite different.
Yeah, hepatitis B is a DNA virus, which is traditionally much easier, pre-COVID, traditionally much easier to create vaccine for. Hepatitis C is an RNA virus and it's pretty conserved, but they just haven't, honestly, I think part of it is funding. They haven't really done a ton of research around hepatitis C because the funding's not there. But hopefully with kind of the movement around COVID vaccine and using mRNA and all of those types of things, there will be a little bit more research into Hep C vaccine.
I was going to mention that, like the second there were trials for the COVID vaccine, I was like, so we can make them. You just don't care about people use drugs. Okay. All right, we're going to skip through our questions. Okay, this is my personal favorite slide, one for the emojis and two because it's my favorite part to talk about. Okay, so continuing with more, just a little bit of information about viral hepatitis prevention messaging, conversations to have with folks. Okay. We've kind of beaten this to death, but A and B can be vaccinated against. Folks who are at risk, please just talk to them about getting vaccinated, encourage it. Hep A, because we're focusing a lot more on preventing that fecal oral transmission. We really want to push hand washing specifically. If you have hand sanitizer, that's great. Hand washing is ideal. And then barrier methods of protection to prevent transmission during sex, so specifically anal sex, of course, because it's a much higher risk of transmission. And then safe injection and drug use practices to the best that folks can do, which we'll talk about that in a little bit more detail in a minute. Hepatitis B is very similar. We want to encourage the vaccine. Safer sex practices, same thing, barrier methods of protection, just like we would encourage folks to have safer sex for HIV prevention. Condoms, dental dams, internal condoms, everything. And then for Hep C, also safer sex practices. And I like to include this because this is a question I get a lot with folks who either have Hep C or folks who are at risk for Hep C, is they're like, can I get Hep C sexually? Is it sexually transmitted? The answer is nuanced. So the answer is it is not transmitted sexually in the way that we think of a traditional STI, because it's not transmitted from sexual fluids. It's only transmitted through blood. But a lot of folks have sex where blood is present. So if you're having sex, if you're having any kind of rough sex, having anal sex, engaging in fisting, anything that is making blood happen, then yes, that is absolutely an opportunity that Hep C could be spread from one person to another. And then also safer drug use practices is what we like to encourage. And lube is your friend. That's a t-shirt that I always tell Christy I wish I had. And that's in the same way that when we talk about HIV prevention, we encourage folks to use lube because we want to cut back on any amount of blood exposure that might happen. Any questions about that one before we move on? Cool. Okay. So we're going to do like the quickest, babyest, tiniest, quick little rundown of harm reduction conversations that you want to have with folks. And so for folks who are at risk for viral hepatitis because they use drugs, not just injection drugs, drug use of any kind, this is a good conversation to have with folks. Because actual injection of drugs is kind of the highest risk for transmitting any of these. We want to encourage folks to try different methods of taking drugs, and that can look like a lot of different things. People can use drugs rectally, which is called boofing or booty bumping. People can smoke drugs instead of injecting them. There are a lot of other options, and we can direct you to way better resources to talk about that. Never share any of your works, any of your injection equipment, not just your syringes, but your cookers, your ties, everything in that picture there. We want folks to utilize syringe exchanges and get as many of these supplies as they need so that they can have them for themselves as much as possible. Because like we mentioned at the very beginning, viral hepatitis in general is a lot more hardy outside of the body than other viruses, especially HIV. So cleaning surfaces before and after with a bleach solution, if you can make that happen, or if you don't, hand sanitizer will work, wiping down surfaces before and after using drugs, washing your hands, hand sanitizer, anything like that. And then of course, using syringe access programs to get all of these wonderful things. We talked about this already a little bit. Different method of using drugs is really important. Like I already mentioned, is just kind of thinking, can you take it orally? Can you smoke your drugs? Anything really, or not even all the time, like any small change that you can make to kind of reduce that risk of bloodborne pathogen is great. Okay. I already said this, but I like to reiterate it and say it again, is that it is, I think viral hepatitis gets skipped over a lot when we talk about STIs because they are not, like I said, traditionally how we think of STIs, but they all can be transmitted during sex. And so it's important when you're having those conversations with people about, for the sake of HIV prevention, like what kind of sex are you having? Anybody who's having anal sex needs to know about hepatitis A prevention, hepatitis C prevention for anybody who's having any kind of rough sex that might cause bleeding. These are all like really good folks to have conversations with about this. Okay, and now we are going to tell you a little bit about our program. I think we only have 10 minutes left, so shall we speed through or keep going? Okay, that's all of us. Aren't we so cute?
The honorary ones. So our program has been in the process of being built for the last 4 or 5 years with the main care continuum of testing, linkage, case management support, linkage, pre-treatment labs, and treatment access. It has grown since we made this slide. So we also approach it with a drug user health approach. So when we talk about referrals, we're talking about not just viral hepatitis referrals, but kind of any comprehensive referral someone might need. Hepatitis C screening and hepatitis B risk-based screening are available through the state lab at any local health department. Also, a lot of our community-based organizations are contracted through the HIV prevention program. We also have a phlebotomist that we contract with through North Carolina Harm Reduction Coalition to offer hepatitis B, C, syphilis, and HIV screening in the field. But as long as folks are falling underneath any of these risk criteria, they're eligible. We try to make it as big of an umbrella as possible. So if folks just say, I'm at risk for Hep C, I want to get screened, we try to push that through and let that happen.
And isn't it part of new recommendations that every adult should have one test?
Yes,
Ever?
so the new CDC recommendations are actually more towards a universal testing approach for hepatitis C. So anyone over 18 is recommended to have one lifetime screening for hepatitis C unless there's a risk that exists. And then it's annually, I believe. Prenatal screening was also included in that for each pregnancy.
And for folks who are getting retested for HIV regularly, a lot of organizations that do that also can do the Hep C test. So not a bad idea.
Same form, same tube.
Same form, yeah, same little tube. So it's good to just toss it in there as well.
And then these are the new testing criteria, our new testing recommendations that came out. I say new, they came out April of 2020. So not a ton of people really picked up the uptake for testing for hepatitis C. The state lab does not follow these yet because it's not necessarily a diagnostic lab or a clinical lab. It's a public health lab, but we're hoping to make some changes in the future.
So this is a good little map to give you a very quick rundown of our Linkage to Care program, which is our bridge counseling program. I am one of the 2 statewide bridge counselors, and we both are in our program based in Raleigh. And then we also help out with kind of the triangle area. So we help out with that middle circle as well. And then the other 4 circles around the state are kind of the jurisdiction that we have 4 regional bridge counselors who they are, like I said, they're placed regionally. And so they are physically there where folks live, and they're able to meet with folks in person to do linkage to care for hepatitis C. And they are all wonderful and we love them.
And we realize that this is not enough people. So it's still not enough people, but we are in the process of placing 7 additional bridge counters around the state. So each region should have one. So that'll be a resource for folks who are testing positive for hepatitis C, folks who want additional testing. They'll be phlebotomy trained as well to offer testing in the field.
And we also have a pilot program that links folks who are tested through one county jail to care when they release. And then I also do a program in partnership with DPS, where everybody who is incarcerated in a prison in North Carolina, if they have Hep C and they're released, I get their name and their phone number. And then I work with them to link them to care, which is a lot of folks, as you can imagine. These are our contacts for if you need to get in touch with any of our bridge counselors, if you know anybody who needs to get into care for Hep C.
We also have our CHAMP program, which is an academic mentorship program in partnership with UNC and Duke. It is essentially a boot camp and a year of telementorship calls where providers can be trained to treat in hepatitis C. So if you know any providers who are interested, please feel free to reach out to myself or Morgan or Anthony Hanna. And we have our next boot camp on February 4th. And then this is slightly not up to date because we've had a boot camp since I've made this map of where we've trained providers through CHAMP. So obviously we have a few areas that we need to focus on, but compared to 4 years ago, where maybe there was a handful of stars on here, we've really been able to do quite a bit of training. Okay. I think this is the end. Yeah. So this is our thing that I just wanted to plug at the end. That is our kind of enormous drug user health resource guide that we maintain as part of our team. This is available. It is on our website. It's on the Epi website for the state at DHHS. It'll be included if you want to look at it later, but it is basically as comprehensive as is possible for one document of resources that folks who use drugs might want or need access to. So it has a lot of information about providers who treat hepatitis C, and it focuses only on those who, in the same way that CHAMP does, it focuses on providers who accept people who are uninsured, because I've been a bridge counselor for 3 years, and I think I've had one person who had insurance. And so everybody in there accepts folks who are uninsured. And then it also has just any other social service that might be important that folks might want. It's got resources for housing. It's got resources for buprenorphine and Suboxone treatment. It has stuff about food pantries. It has everything really that we could think of. And we update it quarterly. We do our best to update it quarterly. And we usually ask that anybody who uses it, if they notice anything that is incorrect or out of date or missing, my contact information is on the first page of this. And so by the folks who use it, they're kind of the ones who help us keep it up to date, because they always know better about what resources are in their area than I ever could. So, and if you take a look at this and see anything that doesn't fit, feel free to reach out to Morgan. I think the deadline is next Friday.
It is. Yeah, it's next
Friday. The other thing important about this is if you hear from folks that a resource on this list is not welcoming to people who use drugs or they had a bad experience, we want to know to see if we can help alleviate that to the best of our ability. And we also don't want to have it as a resource for folks if it's not a valid resource, if it's only going to continue to harm folks and their feelings around healthcare. We do also have office hours the second Wednesday of the month. Please join us.
It's usually just like
it's
this.
usually
It's us and 2 other people
looking at each other over screens.
Yeah.
So this is for any questions about hepatitis. If you have a patient you want help getting into care, if you have questions specifically about hepatitis or a resource or any of those types of things, please feel free. We can send the link out and you can join whenever you'd like. And then these are just some additional fact sheets and resources. The jail screening program, which is technically through the HIV prevention program, but also incorporated with Morgan and Kayla's work. We do have a fact sheet around the 2019-2020 testing there. A lot of it is for HIV and syphilis, but we do have like 20 jails that do Hep C screening.
Mm-hmm.
We have the Hep C treatment and testing algorithm, which is kind of like a quick cheat sheet on how to do Hep C treatment. We don't necessarily want people to just jump in, but it's a nice like guideline. The drug user health resource guide is here, a few of our fact sheets, and a few additional resources around harm reduction in our website.
And then that's us. What questions does anybody have? Any more in the chat or anything? Questions? Thank you so much for being here.
Well, okay, I've got one final question, even though I know we're like a little over time, but doing some vaccine hesitancy work around COVID-19, I was wondering, have you seen any vaccine hesitancy around Hep A or B? And if so, what are those common hesitancies?
In my experience, because like I said, I do linkage to care for folks who have Hep C, and because like unfortunately, but fortunately in this instance, a lot of them are younger, and so a lot of them did get that A and B when they were younger. But the only amount of hesitancy that I have seen specifically is more just generalized going to seek health services, less not nearly as much about the vaccine itself. It's like I went to the health department 5 years ago and they were terrible to me, and so I'm not going back there, which I totally understand. And so a part of what we try really hard to do to alleviate that, Durham County actually just did this earlier this week. The NCHRC, North Carolina Harm Reduction Coalition, has regular weekly outreach for syringe exchange in Durham, and they did a partnership with the Durham Health Department. And a couple of nurses from Durham Health Department came out to street outreach and vaccinated people at the van where they come every week to get their stuff. And that's kind of for us like our gold standard of what we want counties to do.
Yeah, that's been our and really prior to a couple of years ago, that probably wouldn't have been something that could happen regularly with the restrictions around vaccines and what's allowed. But we've been able to partner with the immunizations program, and then also with a lot of the outreach efforts around COVID vaccination, they realize that it's like completely feasible, right, to do it in the field. So we have a single provider who truly drives to people's houses. Tim Nolan, if anyone knows him, he's a North Carolina hero. But he will drive to people's houses after work, vaccinate, put an NCIR. He's held vaccine parties where he gets someone to get a lot of their friends who are interested to come together, and he'll do it vaccine administration. We had a single nurse who just rolled the vaccine cooler behind her through an encampment and offered vaccine. So there've been a lot more movements towards that.
Yeah, we've done a couple. We sadly haven't done any since COVID because I think a lot of jail programs are just not happening the same way. But we've done in the past also kind of like testing and vaccination partnership days with jails. Well, we will go with the health department. Kayla and I will draw blood to do Hep C tests and talk to people about treatment. And then folks in the health department will vaccinate people. And we had the best day we had of that. They vaccinated, I think, 60 people in jail one day, and it was really great. And like we said earlier, you can do A, B, and COVID all together, which is great. Yeah.
Oh, well, thank you both so much for coming and presenting on our Hep A, Bs, and Cs. That was a lot of information, but like still at the same time, it was so needed. So
thank you.
Yes, thank you. Thank you. And thank you everyone who has been attending online and in person. I know you can't necessarily see us, but that's okay. You don't need to see me.
There's a ton of us in here.
There is, right?
It is jam-packed to the gills.
Absolutely.
wall to wall.
Oh, but all right, we will probably be jam-packed starting at 11:45, where we'll be having a conversation about the current state of HIV epidemiology in North Carolina. And I'm so excited to hear about this because, I mean, we always need some updated information, especially in the time of misinformation. So please join us back here at 11:45 for our lunch plenary, and we'll see you all soon.
Thank you.